Hey guys, it's Jake here with Med School Bootcamp. Welcome to our chapter on female reproduction. We're going to start out by talking about the more distal structures like the vagina, and then we're going to move in and talk about the cervix and the uterus and the cancers and pathologies associated with these structures. And then we're going to wrap up by talking about the ovaries and the breast and the pathologies that we can encounter in these parts of the female reproductive tract. So stay tuned and let's get busy. All right, guys, let's get busy talking about internal vaginal pathologies. We're going to be talking about Bartholin gland cysts, imperforate hymen, vaginismus, and atrophic vaginitis. These are all pathologies that are largely going to occur further interior to the labia minora. We're going to have another video that is going to be talking about all the skin pathology of the vagina. That's going to be our next video. So we're focusing on internal structures of the vagina here. So let's go ahead and orient ourselves to some vaginal anatomy to get started. So you'll see here, starting from our external structures, we have our labia majora out here. And then if we were to reflect that, we're going to have our labia minora here. Our clitoris is up here. This is our urethra. And then here, if we reflect the labia minora, we have this hymenal membrane, which you will see is patent. We will talk about pathology later with this membrane. And then here we have our Bartholin gland, which exists at both 4 o'clock and about 8 o'clock bilaterally on a clock face. And then if we were to look at this from the lateral side, and this is the vagina here, and this is going to be our uterus, there are Gartner ducts that line the vaginal cavity, and that is going to be another thing that may be asked on test day, but it's more minor. But I wanted to just orient you guys to this normal anatomy first before we talk about pathology. So talking about pathology, let's start off by talking about our Bartholin gland cysts / abscess. So we pointed out our Bartholin glands, which were these bulbous glands at approximately 4 and 8 o'clock. And essentially these are responsible for producing a variety of fluids to maintain a healthy vagina. And sometimes these can get blocked, and they get blockage, and then they accrue their fluid inside, and it creates a cyst. And this fluid can then go on to become infected. And so essentially it's a progression from Bartholin gland blockage to fluid accumulation in the form of a cyst, and then we're going to get infection. And the way this presents in a classic patient vignette is it's going to be a reproductive age female who may or may not be sexually active, and they're going to present saying, I have some vaginal pain, this is really bad when I'm sitting down, or it's really bad with intercourse. And then a pelvic exam is going to show an inflamed red unilateral Bartholin gland. So usually these are going to be presenting as unilateral. That is classic for this pathology. And so when it comes to management of these, it's pretty simple. It's going to be abscess drainage and then word catheter insertion. So the word catheter is a special rubber tube that facilitates drainage of the abscess. And then in terms of our differential, this could also be a Gardner duct cyst, but this is going to come up much less frequently on the exam. They much prefer to ask about Bartholin gland cysts, so that's why I wanted to really focus on this. So let's just review. It's going to be reproductive age females here, classically unilateral, and then vaginal pain, especially with sitting or intercourse. Let's move on now to talking about our imperforate hymen. And essentially the hymen is a membrane that forms during development just inside the labia minora. An important part of development is that this hymenal membrane should canalize. And when I say canalize, it means essentially make a hole or make a tube. It's just a fancy word for making something patent, making something open. And so essentially, if we take a look here at our vagina that I have drawn here, just to orient you, here's our clitoris and here's our labia minora. Our labia majora would be out here. And then this peachy area of tissue is our hymenal membrane. And normally during development, this gets patent. It becomes canalized, it opens up. However, what can happen in patients with imperforate hymen is that this canalization does not happen. And so essentially they are going to present with a classic patient vignette as a person who is about to start menstruating. So we're thinking 12, 13 years old, and they're getting this cyclic monthly abdominal pain. And this is actually them initiating menses. However, they are not producing any blood or products of menstruation. And this is because everything is trapped behind this hymenal membrane. And it's going to present as a bluish purple bulge because essentially these cyclic menses are getting trapped behind this hymenal membrane, and it's causing pelvic pain, it's causing abdominal pain. And then if you were to do a pelvic exam, you would see this bluish discoloration, which is all of the products of menses that are trapped here behind this tissue. And in terms of treating this, it's pretty easy. You just have to go ahead and open up this membrane. This can be done surgically, and it's going to relieve these menses that are backed up, and it's going to help with the canalization of this hymenal membrane. So in terms of review of our imperforate hymen, it's going to be failure of our hymen to canalize during development, and this is going to present as a pubertal age patient with cyclic monthly abdominal pain. This is technically a form of primary amenorrhea because even though they are initiating and having their menses internally, this is not able to be finished by actually pushing those products out of the vaginal orifice. And we're going to say this is going to present with a blue or a purple hymenal bulge, and then the management here is going to be a hymenectomy. Now I wanted to point your attention down here to our diagram here where we have different types of imperforate hymen. So here would be a normal hymen where we have this vaginal orifice that is open here. However, we can have variations of imperforate hymen. So we talked about the completely imperforate hymen, which is completely closed, where we can have things like cribiform, which is a collection of little dot holes, or we could have a septate hymen. It's not incredibly high yield to know these different variations, but I wanted to put it here for you guys if you're interested. I would really focus on the fact that we're going to have this cyclic monthly abdominal pain and this blue purple hymenal bulge. That's going to be what is high yield on exam day. Now let's move on to talking about vaginismus. And vaginismus is going to be involuntary contraction of our vaginal muscles, especially with insertion of something. So this could be insertion during intercourse, this could be tampon, this could be pelvic exam. And essentially we're going to have this involuntary contraction, and this is going to lead to vaginal pain. And this can be with insertion of anything, even during voluntary insertion. And so this is going to present as someone with pain during intercourse or pelvic exams despite willingness to have something inserted in the vaginal canal. And usually in classic patient vignettes, this is going to be interlaced with some sort of mental health issue. So usually we're thinking anxiety or depression or maybe a history of sexual abuse. That is going to be really high yield in connecting this to vaginismus. So I'm going to highlight these three things for you guys because they are nearly always going to be in a question around vaginismus. And then this is going to be clinically diagnosed by visualizing this vaginal contraction that's going to happen during a pelvic exam. And in terms of treatment of this, it's not super high yield on step one, but it's essentially going to be mental health type treatment. So like cognitive behavioral therapy and working through patient with like relaxation exercises and things like that. Finally, let's talk about our atrophic vaginitis, which is going to be atrophy of vaginal tissue in the setting of low estrogen. And so our low estrogen here is going to create a low vaginal blood flow state, and this is going to decrease the secretions from our vagina, leading to vaginal atrophy. So we mentioned earlier on in this lecture that things like the Bartholin glands and the Gartner ducts are really important for lubricating the vagina and ensuring that it's in a healthy state. However, in low estrogen states, this activity starts to decrease, and some classic low estrogen states are going to be menopause and pituitary dysfunction, or maybe a patient is on an aromatase inhibitor, a classic example which is anastrozole. And these patients are going to present with the complaint of thin and dry vaginal skin. They may have itching or pain because this area is not well lubricated and it's causing friction, and we're getting like loss of flexibility in those tissues. And then we can also have altered vaginal pH because these secretions are not at their normal amounts. And so you may have a patient who gets a complication from this altered pH. Perhaps a candida would be a classic infection that's going to occur with altered pH. And remember, this is going to present as like a cottage cheese-like discharge from the vaginal orifice. So in terms of fixing this and treating this, we can identify the underlying cause of their low estrogen state. And if this is manageable, we can fix that. But if it's not, like in the case of menopause, then we can go ahead and provide topical estrogen creams, which are going to help revitalize this vaginal tissue. And we can also provide water-based lubricants to help with things like intercourse or tampon insertion, etc. So in terms of a high yield review for this video, it's important that we focus on our anatomy. So knowing our internal structures are going to be really helpful. And then knowing that Bartholin glands are usually going to be unilateral and present with pain with sitting and intercourse. And this is due to blockage or infection of these glands. In terms of imperforate hymen, the cyclic abdominal pain accompanied by this blue/purple hymenal bulge is going to be really high yield, and this is going to be managed surgically. In terms of vaginismus, I really want you guys to focus on the incorporation of some sort of mental health aspect to these question stems, and the fact that it's going to be insertion with anything despite willingness that causes this involuntary vaginal contraction. And then finally, we wrapped up with atrophic vaginitis, which is due to our low estrogen states. Classically, this is going to present in a menopausal patient. However, it can be anyone in a low estrogen state, and we're going to manage this with estrogen cream. as well as water-based lubricants. So I really hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye!